Good evening, all the doctors who have joined this webinar. And we are starting this new concept, new idea of these webinars, wherein we will be sharing our knowledge and experience in teaching the important topics for all the general practitioners. So firstly, we will deal with all the emergencies which you people will encounter in the practice. The beauty of this webinars is that it will be stored and can be played again whenever you want. So we will be creating a sort of a library. The first important thing which I feel the doctor should know, even at a primary level, is that they should be able to read the basic ECGs of important diseases. And I am going to try very much in the every webcast later to teach the basics of ECG. Importantly, your suggestions and feedbacks are very important for us to make this program successful. In fact, I call this that this is going to be a long-term association between all the doctors and our consultants of our institution. It is not only teaching one way, but we will also be learning in this process. And also we will be sharing important cases which we deal with, which will subsequently, you will be able to learn some of the important points. Today, the most important topic today is if you are a general practitioner in your OPD and you get a patient of a severe chest pain coming to you, and it is very baffling, very confusing. So what one should do? And you keep on hearing the word PAMI or primary angioplasty. What is it? When is it required? And how to do it? So with this background, we will understand some basics of the cardiac physiology and pathology of the disease called as the acute coronary syndrome or ACS. The heart, as you know, is a pump which keeps on pumping the blood about 70 to 80 times per minute, and it continues right from early childhood or even earlier during the fetal life to the end of life. This muscle, cardiac muscle, requires blood supply which is provided by three main arteries. The name you should remember, one is on the right side called RCA, right coronary artery. The left is divided into important artery, left anterior descending or LED, and a posterior artery which is called circumflex. And the various branches of that give the adequate blood supply to the heart. Now what happens is that the vascular disease develops after the age of 40s commonly, but nowadays it is developing earlier also. So in this what happens, because of the risk factors which we are very well aware, the intima, the inner lining of the artery, there starts getting deposits of lipid rich cholesterol, and it is called as a plaque. So many plaques develops in the arteries. It's not only coronary arteries, all the arteries in the heart, brain, kidneys, aorta. So these go on increasing with age. And normally, in a stable condition, it is covered with a lining which is called a fibrous cap, and that is how the blood flow through the remaining portion continues. When this process of obstruction is more than 70%, then you will start getting, after walking for 1 kilometer, 2 kilometers, you will get the chest pain, or this is called as a stable angina. And in an acute coronary syndrome, a different pathology comes through. In this second picture, the fibrous cap is ruptured. This rupture causes the platelets to aggregate there, forms the platelet thrombus, and almost near total occlusion of the artery can occur. Also, there may be a red thrombus, the blood there, clot there, red clot, and it will block completely the artery, and this will lead to the ACS, which we will see later, and this leads to the blackening of the part of the myocardium, which is an infarcted zone depending on the artery where it is blocked, and it causes the heart muscle to be dead. So this is a typical diagram. This anterior artery LED is blocked and it is producing an infarct in that particular zone. In this, the arterial atheroma is seen as a yellow thing, and then the formation of a blood clot, the blood flow through the artery is completely ceased. Now this is a commonest disorder all over the world, and more than millions of people have experiencing myocardial infarction each year. Earlier, when there was no ICU, the mortality of MI was more than 30%. So out of 100, only 70% will survive, that too also with LV dysfunction. With the development of ICUs, it fell down to 15%. And now, currently, with thrombolysis as well as the primary angioplasty, it is come down to 6 to 7% and will come down further. You are very well aware of the why it causes this. So as you know, any patient who comes to you with chest pain, you should ask him about the blood pressure, hypertension, smoking, diabetes mellitus, whether he is active or inactive, exercise, whether he is obese, and his lipid profile, high cholesterol, in addition to more common in males and also common in elderly, but in Indian setting and Asian setting, the younger and younger people are getting admitted. So in fact, in our hospital, about at least 1 or 2 young infarcts are there at any given round. So in the same way, the diagram is showing a normally flowing artery, progressive occlusion of that artery, and then later on there is a blood clot formation and will produce myocardial infarct. Same thing in a diagrammatic fashion. The stenosis keep on occurring, there is atheroma and will cause narrowing. So the same thing I said, finally it is a muscle necrosis which leads to myocardial infarction. So basically we are talking of the plaque which has ruptured with a thrombosis, the blood supply to the heart is interrupted, and now when this happens, I told you already that stable angina is a different thing where the plaque is not ruptured. But when you call it ACS, there is a plaque rupture and it has 3 major clinical points. One is that most important where there is a ST elevation MI called STEMI, and which is a complete occlusion will be there. And second one is non-STEMI where the ST segment has not really gone up and we will see the ECGs there. And the third is unstable angina. The difference between the first and second is that in first ST elevation is there, and in non-ST there is no ST elevation but there will be depression. In unstable angina and these two, the differentiation is based on the enzymes troponin I and troponin T, which will be raised in number 1 and number 2, while in number 3 unstable angina the troponins and CKMB are normal. So to summarize, unstable angina is non-occlusive thrombus, ECG changes are not specific, and importantly cardiac enzymes are normal. So that means that any patient who comes with a chest pain which is of significance, the cardiac enzymes are necessary. We will see more details later. In non-STEMI, which is again a non-occlusive thrombus, but it causes the muscle damage. It causes some degree of myocardial necrosis. It will cause ST depression or T inversion on ECG. I will show you the ECGs, and it is the troponin and MBCK are raised. While in STEMI, which is the most severe form, both these are severe, but STEMI is more severe. The algorithms are different. There is a ST elevation in the ECG. or it may be new onset LBBB, elevated cardiac enzymes, and symptoms are typically more severe. So again, in the same way, it is a spectrum of acute ischemia. It is ischemia of the myocardium in all these three, from the unstable angina, N-STEMI to STEMI. This is what is the pattern. So we will be discussing all this pathophysiology of ACS and how to really deal with it, which are low risk cases, which are high risk cases of ACS, which one should know. If you are dealing with a high risk ACS, then you will have to act immediately, otherwise there will be the death. So whenever the patient is coming, you have to scenario is that the patient is come to your OPD with a chest pain. So firstly you will take a history, you will examine the patient. The third thing, important thing is that you should have an ECG in your cabin chamber and try to take an ECG. Blood investigations, echocardiograph, cardiac catheterization will be done in a hospital. Now, the chest pain comes. Patient with chest pain come. You find out whether what is the length of the time, 1 hour, 2 hour, whether intermittent or it is constant. Where it is a location, whether it is retrosternal, going to the shoulders, arms, sometimes the neck, it is sometimes jaw, it may be mild, and in especially diabetics it may be only discomfort or no pain at all, or it may be excruciating severe pain. So that is a spectrum of MI and ACS. Many times it happens that people present with something like they feel, the clinician feels that it is almost like a duodenal ulcer. The typical description is compressing and crushing of the chest, but this is seen only in 30 to 40% of people. So you have to know, in addition to this, if there is a patient with a typical retrosternal pain with radiation in both arms, is very, very diagnostic, very suggestive. The sweating association is also very important. Vomiting may be there. Some people, diabetics especially, they will complain only of restlessness, and occasionally you will get a patient who is really in shock. Patient's blood pressure is less than 90 systolic. That is the definition of shock. Or the patient with an infarct may present as syncope. Patient has fallen down when he is going to the toilet, he had some chest comfort, and when he comes to you, it will be mainly because of bradyarrhythmias or complete heart block. As I told you just now, the location will be substernal, there will be radiation. You all should know these features, what is the duration, and nitroglycerin some people take, you also can give it, and whether it is relieves with nitroglycerin or not. So this is a mnemonic, PQRST. What is precipitated in exertion, anxiety, type of pain we just said, radiation of pain, severity of pain, and how long it has lasted. Importantly, when the patient comes to you in the clinic, just check his pulse. It may be a normal heart rate, it is okay. If it is severe bradycardia, you know that you are dealing with probably an inferior infarct with complete heart block or sinus bradycardia. And if the patient is having tachycardia more than 100, then the patient may be in shock. Just check his blood pressure. There may be cases where there is because of anxiety tachycardia occurs, blood pressure may shoot to 160, 200. A patient who is gone into left ventricular failure, there will be crepitations. And if you can appreciate a murmur, that is good. So this is a basic examination findings which you should do. Note down the pulse, note down the clinical, whether he is sweating and what is the blood pressure. And so these symptoms, and these are unique to each individual. There will be a fairly, all of you are senior, many of you are senior, and you must have experienced many such patients in your this thing. I must tell you one doctor from nearby town, his symptoms were so mild and he wanted to see me, but somehow I was busy that day, so he said he will go back and next day morning he will come. In the evening the message came to me that he is no more. So understand the symptoms can be mild. You will get, for all of us will get frustrated at not diagnosing it in time. So understand the minimal the symptoms are also very important. Now when a patient comes to you with a chest pain, I will not go into the great details of that, but I want you to remember, if there is a very severe pain and especially back pain is there and the blood pressure is high, then you are dealing with the aortic dissection. We had many patients and this patient requires emergency surgery. The pulmonary embolism is another possibility which should be kept in mind, but this will require referral to the hospital. It has happened that the patients with esophagitis and this are initially wrongly admitted, but there is no option. You have to admit these patients and do his echo and also troponin and then decide after 1 or 2 days. The chest pain may be due to costochondritis concerning with the ribs and the joints, rib fracture, and I have had many cases where there was a herpes zoster was there, the rash was not there, and only after a few days the rash came up. Anxiety and also this also can be part of the. We are dealing with now unstable angina, and in unstable and stable angina, basically in unstable the pain occurs in rest. It will be of varying duration, new onset. The pain may go on increasing, and the drugs which the patient was on all previously are stable angina, they are not really controlling this thing, and the ECG may be normal, ST depression and T may be there. So this is unstable angina, and in this unstable angina and this in the hospital you have to decide which is high risk. If it is high risk, then the patient has to be done a very early invasive therapy in the form of doing a quick angiogram. So if the patient comes to us in the morning or afternoon, and we find that this risk is high because of his troponins, because of the risk factors, ECG changes, and the many episodes of chest pain, then we will take him in cath lab within 1 or 2 hours. In a case of unstable angina. Now, unstable angina and ST segment, the non-ST MI are essentially, I will show you the ECG changes in N-STEMI, and N-STEMI is as dangerous as STEMI where there is a ST elevation, and so these are the ECG which I am talking about. Slightly, they have shown normal, but it will be completely normal. So this is normal ECG. Now here, the second one, it is showing that the ST over this baseline is elevated almost 5-6 millimeters. So this is a typical STEMI ECG, ST elevation. This is non-STEMI, that is ST depression may be there or there will be T inversion. These are the two patterns of N-STEMI. ST elevation is a pattern of STEMI. Am I clear? The patient comes with the ECG, patient is showing ST elevations. The cardiac enzymes are not really necessary. Cardiac enzymes these are the ones which are released because of the muscle is damaged. These are the release from the damaged muscle into the bloodstream. CKMB and troponin. Troponin is now currently the fashion. Most people will troponin. There are two: troponin I and troponin T. Different labs have different standards, and it is will not go into the details. The normal value is differing, but in our lab it is 0.01. Anything more than that is abnormal in our lab, but some labs have up to higher values. Importantly, if the patient is complaining of chest pain and you have taken the blood in 1 hour, it may not be elevated. So you have to minimum wait for 6 hours before you do these tests. And only after 6 hours, if you have taken a first sample, then you have to take a second sample after 6 hours and then decide. These remain in the blood for 3 to 10 days. So this is a typical pattern. The red one is a troponin and first 6 hours there is a gradual increase, and after 6 hours there will be, you will be detectable this, and these remain in this for 7 to 10 days. The patient with a chest pain whose ECG is showing either ST elevation or ST depression, you have categorized him. You have said the patient is in a hospital or in your small hospital. You have sent the blood for troponin, which is elevated. Or even if you are not sent the blood, because blood will take some time to come, the echo is very essential. Echo will many times will give a diagnosis of infarct, which artery is likely to be involved, and also will rule out aortic dissection. So it has happened in our hospital. Patient came with a chest pain. We did not know, we had no time to take ECG also, but the echo was quicker investigation, and we diagnosed aortic dissection there, and then the patient was taken for immediately surgery. Some of these aortic dissections may not survive for even half an hour. Now, location of infarct will be decided by the ECG. So people who are familiar with the ECGs, the V1, V2, V3 will be the septal or anterior up to V4, and these are V5 and V6. Some cases where a large infarct is there, ST elevation V1 to V6, it is called anterolateral infarct, anterior also and lateral also. There will be only lateral, in which there will be one AVL, and these are there. This I will show you the ECGs, and I will not discuss this. Inferior infarct, where the RCA or circumflex will be involved, will be 2, 3, and AVF will show ST elevation. So this is a typical ECG of V2 and V3. This is a shouldering, just like a shoulder. ST is elevated. This is a J point, and from J point is elevated, and this is a called also tombstoning. There will be reciprocal changes in the inferior leads. Anterior is elevated, so the opposite leads will show depression. In the inferior, again, exactly opposite, 2, 3 AVF will show elevation, and 1 AVL V5 V6 will show depression. So this is this thing where this is lead 2, 3, and AVF ST elevation is there, and AVL is showing the depression. So this is a typical inferior MI. We will not go into the posterior MI, is a specific subset where the R wave is prominent in V1. Lateral MI is where the either ramus or the one branch which is called as a diagonal is affected, and ST elevation occurs in only V5, V6, 1 and AVL. So this is a detailed this thing. You will be able to study this in a stored format later. Anterior will be 1 AVL, V1, V6 elevation. Lateral will be 1 AVL. Inferior are 2, 3 AVF. And if there is a right, in a RCA, supply the right ventricle, the right sided leads, V1 and V4, will show the elevation, and lead 3 will be more than 2. So the patient has a normal this thing. This is a time sequence of the ECG. This is when the patient is come, say within 1 hour ST elevation, and ST segment has not become convex, and this is called hyperacute STT changes. The patient is very, very fresh. You will have to act. Then after few hours, almost similar thing remains unless you thrombolize the patient or you do a primary angioplasty. And then the days later on, the ST segment will settle down and the T inversion appears. So this is a typical evolution of ECG changes. Now, the patient has come to you. You don't know whether it is elevation, ST elevation or ST non-ST elevation. The patient is having severe pain and you don't have any other alternative diagnosis you have made, and you want to at least, the question is, should we give something or not? Or should we just refer the patient? Now, if you are sure that you have ruled out the other gastric causes, other causes, pneumonias, Fever will never be there initially. So if there are conditions are ruled out by a clinical examination, the patient appears to be a coronary event, then I will suggest that you give aspirin. It should be a dissolved aspirin, not entry coated, and 150 to 325. That should be the initial doses, sublingual. Clopia, I will request you not to give it, because if you give this, then the CABG is not possible later on. One important drug which you should give is atorvastatin 80 or a high dose statin or a rosuvastatin 40. Now, in the hospitals which are treating, they can decide about beta blockers based on the echo, the ramipril, the heparin, and in folic acid in young people. This you can decide, but this is only after ECG and echo. If you have not done anything, then you can give aspirin, atorvastatin, and you can give sublingual sorbitrate. These are the things which you can give. If you have more confidence, then you can give either a heparin or low molecular weight heparin. Clexane can be given. Depending on the weight, you can give either 0.4 or 0.6 subcutaneous. Now you know that his artery is blocked. Coronary artery, one of these is blocked. So what is your aim? Aim is that artery, you want the blood flow to start again. You want to remove that block. Why you want to do that? Because you want to prevent the myocardial damage. The muscle, once it is dead for more than 6 to 12 hours, I will tell you later, then it cannot come back. The patient's entire life will be with a LV dysfunction most of the times. That is why the time is crucial, and it is called time is money. Blood flow restarting will reduce the mortality, prompt recovery, long-term survival and quality of life. If you don't restore the blood flow, which we will see in some cases, then these are the immediate mortality, long-term mortality, quality of life is suffered because of the LV dysfunction. I keep on seeing patients who come late or who are just thrombolized and the thrombolysis has failed, the artery is not open, angio is not done. Now these people will have continued to have LV dysfunction, ejection fraction typically 35%. I feel very sad that he should have come. So how will you open the artery? The patient can be taken in the cath lab. I will show that procedure. You pass a wire, you pass a balloon, inflate the balloon, start the flow. There are some drugs, other things are given. You may stent or you may not stent, depending on the anatomy. The second option is intravenous thrombolysis. You have heard streptokinase, tenecteplase. These are commonly used drugs in our settings. So these are the two main strategies. One is a primary angioplasty, second is thrombolysis. We will see the benefits and the disadvantages of each one. Now, this worldwide, this is studied. When I had been to US and Europe, so I said, what do you do? I asked the cardiologist, what do you do about the infarcts which thrombolytic use? He says thrombolytic agent is not available in our hospital in last 3 years. So you understand that worldwide, everywhere, no thrombolysis is done unless in a very specific setting which we will see. So we are talking of the STEMI. I told you already you will give anticoagulants, antiplatelet, and then option for you is a thrombolytic or PCI, and in an unSTEMI situation, you will give the similar drugs, and there you may treat medically, or if the high risk features are there, you will do the angiography. So basically two options. In US and other countries, there is another option. It's a pre-hospital thrombolysis. The patient's ambulance goes there, and in the ambulance itself, they can take a ECG, they will send to the cardiologist, and if it is going to take more than 2 hours, 120 minutes, then he will initiate thrombolysis there. In remote places in other countries, advanced countries, they will still thrombolysis only for that indication. In our setting, many people, except who are from Konkan, there Konkan also lab, you have to send to the lab where they will do this. Now primary PCI, can you do for all people? Yes, practically all people you can do. And where you have to do is that, patients coming early within 12 hours, first 3 hours of chest pain, you can still thrombolyze even in our setting. But beyond 12 hours, in fact 6 to 12 hours, the role of thrombolysis is not there. In fact, it will cause more damage. If the patient is above 75, then the necessary thing should be primary angioplasty. Why? Because thrombolysis will cause intracerebral bleed. So some of the points, why PAMI has been accepted worldwide. Reperfusion rate 90%, thrombolysis will be 70-80%. Recanalization 95%, and in some cases there will be none here. In almost 25%, 20 to 30%, the artery will remain blocked. That is the main problem of thrombolysis. And how to come over it, I will tell you. This is single step. You have done PAMI is over. Just continue the drugs. What is required is you require a lab which is working all day and night. Expert team, cardiology should be available. So these are called PAMI capable hospitals. In thrombolysis is best in first 3 hours. After 12 hours, it is harmful, class 3 indication. I told you more than 35% no perfusion. Now, if the patient comes to a PAMI hospital, they should be able to do this within 60 minutes. This is a recommendation. In thrombolysis, there is, I told you, pre-hospital thrombolysis. These people can bleed 2% stroke and ICH, intracranial hemorrhage. 20-30% they will be failed thrombolysis. The block remains. In 50%, failed thrombolysis means the ST depression occurs, elevation is not reduced. ST elevation remains, and then you have option either doing repeat thrombolysis or sending the patient to the cath lab. So I told you primary angioplasty is very important in securing and maintaining patency, low rate of death, low rate of infarction. So this is there. In 120 minutes you should reach the lab. So I think most of Kolhapur district people will be able to achieve this. 120 minutes should reach. In 90 minutes I will do the PAMI, and thrombolysis in our hospital also reduced only after, I will tell you that. So someone has come before 12 hours of symptoms. If the patient is in shock or mechanical complications or failed thrombolysis, you are given a thrombolysis and ST segment elevation has not come down, chest pain is persistent, then you should do the angioplasty. For these mechanical complications, CABG is the best option. We have had many cases in last week only where there was a rupture, mitral regurg, and VA development of VSD. I will tell you a word about pharmacoinvasive. Suppose the people are sent to the non-cath lab institutions, hospitals, where they will use thrombolysis. Now this thrombolysis, whether successful, should be followed within 24 hours by invasive treatment. So the angiogram should be done before next 24 hours, and open the artery. That is a recommendation and that should be followed. Now after 24 hours, only if there is a failed PCI, TVD showing a lot of calcium, we do angio, TVD is there, that time CABG will be required. If there is a heart failure or arrhythmia, you should do a PTCA. A completely occluded artery patient comes after 3 days of thrombolysis, artery is occluded, the PCI has no role. So following STK, this thing, do the angiogram in 3 to 24 hours. Between 12 to 24 hours of chest pain, only option is PCI. If it is severe TVD, CABG. Heart failure, arrhythmia is there, do a PCI anytime. Total occlusion more than 24 hours, no PCI. What are the complications of this thing? Sometimes the patient will come to you with a shock, patient dyspneic, heart failure, and these complications. Now, you have got an infarct in your clinic. You know that either you have taken an ECG or you are sure that it is an infarct. You should send preferably to the center which has cath labs, which is around the clock, 1 or 2 or 3 cardiologists. They are available 24/7 and fourthly they should be affordable. So if you send a patient to our hospital during daytime, it is 9 o'clock to 6 o'clock, we will do the primary angioplasty of the patient without giving thrombolysis in all of them free of charge under the Yojana if they have the card. If they come after 6 o'clock, then we will thrombolize them and use a pharmaco-invasive therapy, that is before next day morning, before 24 hours, we will open his artery. Some cases, angiogram, CABG is required, and in angioplasty, I will show you some examples. This is a lesion, balloon is put, stent is inflated, and the lumen is normal. Some 2-3 examples I will show you and then close. These were all, I think, last 2-3 weeks only we had these examples. One was a 70-year-old female, 3 hours of pain or profuse sweating. They show the anterior MI, and on admission they were requiring 2 times in Nipani it had ventricular tachycardia. Came here, there was a VT also, we cardioverted it. EF was well preserved. We see the thickness of the myocardium. See this elevation, V2, V3, V4, V5. So this is a trans anterior or anterolateral MI, and this was taken for, this is a LED artery. You can see that totally occluded artery is there, calcific artery, no flow down. After the wire, we put a stent here, and the artery is big and huge, and the patient immediately, when the patient recovers in a matter of few minutes. Believe me, by next day morning, because of Yojana, we are able to discharge these people next day. So this is the beauty of this primary angioplasty. Another patient was younger, 5 years pain, again anterior. You can see the ECG, beautiful ECG. This is a convex shouldering, which I showed you earlier. And this is called sky high ST segment elevation. If these people are there and you wait thrombolysis fails, then this patient will not survive. Because thrombolysis failed. Sometimes the thrombolysis will fail 30% of the times. So if possible, try to open the artery like everywhere in the world by doing primary angioplasty. This was again a LED. We have put a stent here to the totally occluded artery, and see this again, flow is established. The details of the procedure we will discuss in some of the. This was 75-year-old, very elderly lady, and very bad inferior MI, complete heart block. And we took the patient, the 2-3 AVF was showing this. And this right coronary artery stump is there. Entire artery is blocked. So you can see this is a pacemaker wire here. Patient was having complete heart block. You put a wire, paste. This is a wire here and then a balloon here, the right coronary artery, and establish the flow. As I told you, the main aim is start the flow, the muscle will recover if you have done in time. Earlier the better. Every hour is important. And the dictum is the time is muscle. You take the shortest possible time. If you send to a center where the doctor is not there, he will come after 2 hours. Those 2 hours are very crucial. You should try to do these things within 3 hours. Another man, inferior A, this is circumflex. This is the third one. So we put a circumflex artery, all 3 arteries I am showing you. These are all the cases done last week and very beautiful results. And I am coming to end of this thing. If there are any questions, we will try to answer now or even my next webcast, which will tell you, we'll streamline it. We possibly every once in a 2 weeks will be there. And I want you to give your feedbacks, what you learned, what you did not learn, what you want we to change our presentations. So these are my numbers. Don't feel awkward to call me for this. And my senior marketing people, PROs, Satish and Mahesh, you can contact them in case I am not available due to any reason on phone. And then we'll try to do our best for the patients. I think if we are able to give this PAMI program, and now 118 is there, that will reach very fast, and it is a beautiful thing to treat an infarct, make him survive, especially 70-year-old, 75-year-old or a young person. And so with that, thank you very much for attending. So thank you again. Bye-bye.